Welcome back guys. Now in this video, let's discuss about medical termination of pregnancy. Now let's begin the topic with the MTP Act. What exactly is this MTP Act guys? Medical Termination of Pregnancy Act, which came in 1971. Now this act will give us all the guidelines for performing the medical termination of a pregnancy. According to this act, we can only perform MTPs in India before 20 weeks only. Okay, before 20 weeks of period of gestation, a female can go with the medical termination of pregnancy. Once she crosses 20 weeks, MTP should not be done. Okay, MTP should not be done. Now please concentrate. For performing MTP, the doctor, whoever is performing MTP, he should be having at least 6 months of training in the gynecology. Okay, the doctor, he should be first of all having a degree of MS Gynecology or DNB Gynecology or DGV Gynecology, and at least a training of 6 months is required, and the doctor should be performing or assisting, okay, not performing, assisting. Okay, whoever wants to get a qualification for MTP, they should be assisting at least 25 MTPs under supervision. Okay, and for performing a MTP, the consent of the partner is not required. Okay, the partner's consent, okay, usually the male partner's consent is not required. The female's decision alone is enough for conducting MTP. Okay, now after this guys, we have discussed about the MTP Act 1971, but there is this new MTP Amendment Act which came in 2020. Okay, it gives us some new guidelines and new recommendations. Important point is, still this act doesn't take in a form of law. Okay, in future it will be like going to take a form of law, but still now we are following the MTP Act 1971 only. Now let's see what 1971 MTP Act is giving guidelines and what are the new recommendations which are seen with the MTP 2020 Amendment Act. Now see, MTP 1991, it says us MTP should be performed only till 20 weeks. After 20 weeks, don't do MTP. But new recommendation is that you can perform MTP till 24 weeks. Important point. In your exam, if someone asks you, in India, till which period of gestation MTP should be performed? The answer is 20 weeks only. Why? Because these are just new recommendations. Okay. Still, these new recommendations hasn't taken a form of law. Now, MTP 1971, it says that if the period of gestation, if it is between 12 to 20 weeks of period of gestation, okay, now the female, now she is having a pregnancy which is between 12 to 20 weeks. Actually, she have to take the opinion of 2 doctors. Okay, 2 doctors should give consent for her that she can go with the MTP. But what are the new recommendations? New recommendation says us, see, before 20 weeks, okay, before 20 weeks, 1 doctor opinion is enough. After 20 weeks, that is 20 to 24 weeks, please concentrate. In between this time, 20 to 24 weeks, you need to have 2 doctors opinion, but between 12 to 20 weeks or before 20 weeks, just 1 doctor's opinion is enough. Previously, we will never do abortion. Okay, according to 1971 Act, see, we won't do abortion of a severely malformed fetus after 20 weeks. Okay, after 20 weeks, we won't do any abortion. But new recommendation is saying us that if a baby is gravely malformed, okay, severely malformed, there is a severe congenital anomaly, you can do abortion or you can do MTP. I shouldn't be saying abortion, you can do MTP at any time. Okay, anytime you can do the MTP. So these are the new recommendations. Now after saying this, let's talk about the abortions which can be done in the first trimester and second trimester. There is no such thing as third trimester abortions. Okay, so first trimester, second trimester. Now let's see first trimester medical termination of pregnancy and second trimester medical termination of pregnancy. Now guys, see, you can terminate the baby in first trimester using drugs, that is a medical abortion. You can also do medical termination in first trimester by doing suction evacuation, by using the suction, okay, by using the suction power, you are terminating the pregnancy, or manual vacuum aspiration, okay, dilation and curettage. See, these are the methods which are performed for terminating the pregnancy in the first trimester. Now, in the second trimester, you can use the medical methods. You can go with the dilation and evacuation by using ovum artery forceps. Okay, by using the ovum forceps, you can do that. Why? Because in second trimester, simple dilation and dilation and curettage or suction evacuation is not enough. Why? Because the baby has grown big. So what you are doing is dilating and evacuating the fetus with ovum artery forceps. Okay, you are going to take the baby in the form of parts. Okay, you are going to make the baby into parts and you are going to take out all the parts, that is dilation and evacuation. You can also go with the hysterotomy. Okay, you are opening the uterus and you are taking the baby out. Okay, if the above methods, if they are not helpful, you can go with the hysterotomy also. So this is broadly about first trimester medical terminations, second trimester medical termination. Important point is that, see, either it's in first trimester or second trimester, we will usually follow medical abortions only. Okay, so medical abortion in first trimester and medical abortion in second trimester are the most commonly done terminations. What is the important difference between them? See, in first trimester, you can do medical abortion as a OPD management. You can give certain drugs to her. She will be taking those drugs in her home and she will be having a bleeding. Okay, she will be having bleeding and she will be having the abortion. So, first trimester medical termination is actually a OPD management. But in second trimester, the patient needs to be hospitalized. That's a very important MCQ. Okay, the patient should be hospitalized and you are giving drugs under your supervision. Okay. Now, after saying this, let's see some important image-based questions, guys. See, suction evacuation is done with an instrument known as 𝐒𝐻𝐪man's cannula. Okay, whatever you are seeing here, see, this is a plastic rod-like structures. These are known as 𝐒𝐻𝐪man's cannula. And here, the image is showing you, it is ovum forceps. Okay, ovum artery forceps. Important points to identify ovum artery forceps are, you will be not having, okay, there won't be any catch here. Okay, in the distal portion there won't be any catch, and like proximally you will be having a spoon shaped edge. Okay, spoon shaped, the edge is going to be spoon shaped and there is no catch in the distal end. Okay, distal end. And also please concentrate here, the image which you are seeing here is a manual vacuum aspiration. Okay, manually you are going to create a vacuum. With that vacuum you are going to aspirate the contents of the uterus. So these are some important image based questions we will discuss in detail, don't worry. Now let's talk about the medical abortion in the first trimester. Guys, medical abortion can be done up till 9 weeks. Okay, according to the WHO guidelines, 𝐴COG guidelines, we can do medical abortion till 9 weeks. But usually in India, according to the guidelines, we will do medical abortion up to 7 weeks only. But medical abortion can be done till 9 weeks. Okay, till 9 weeks. After 9 weeks, we will follow certain other methods, not drugs. So first 9 weeks, you can terminate a pregnancy just by using drugs. Okay, in India, we will do up till 7 weeks only. Now, see, before conducting a medical abortion or whatever the mode of abortion or whatever the mode of termination, see, first you have to confirm the pregnancy is a intrauterine pregnancy. See, there is this female who came to you and she says that, doctor, my urine pregnancy test is coming positive. I just don't want to have a baby. I just want to go with the abortion. See, don't simply jump and do the medical abortion. What you have to do is first confirm the pregnancy is an intrauterine pregnancy. Okay, rule out ectopic pregnancy. Why? Because if you do medical management for an ectopic pregnancy, that's not going to helpful. Okay, that's not going to be helpful. So, medical management for ectopic pregnancy is absolutely different. Here, medical management for termination of pregnancy is absolutely different. So, first what you have to do, always by performing ultrasonography, confirm the pregnancy is an intrauterine pregnancy. Having said that, let's see important points about first trimester medical abortion. Important point is medical abortion can be done up till, okay, medical abortion can be done up till 9 weeks. But wait, in India, it is done up till only 7 weeks. So let's see what exactly we are usually doing. On day one, what I'm giving, I'm going to give a drug which is known as a mifepristone or RU486. Okay, RU486. What kind of drug is this? See, this is anti-progesterone. Okay, anti-progesterone. Actually, in pregnancy, the most important hormone is progesterone. So, progesterone is the one hormone which maintains the pregnancy, which maintains the baby. If you are giving such kind of anti-progesterone means it's going to kill the baby. Okay, how you are giving this drug? Orally, and how much amount of drug to be given? 200 milligrams. Okay, not micrograms, milligrams. 200 milligrams of mifepristone given orally. It kills the baby because it's an anti-progesterone. Okay, you have killed the baby successfully. Now what to do? You have to take out the baby, right? You have to cause the expulsion of the baby. Now for that, what you will usually do is, see, I'm going to give a drug which is a uterine contractant. Okay, I'm going to give a drug which causes the uterine contractions. Because of this uterine contractions, there will be expulsion of the dead baby. Okay, so what is that drug? Misoprostol or misoprost. How much I'm giving? 400 micrograms, not milligrams, 400 micrograms. Actually, this misoprost is nothing but prostaglandin E1. Okay, prostaglandin E1. What it is doing? It's going to cause the uterine contractions and it expels the dead fetus. What is the route of administration? Sublingually. Most preferred route is sublingually, or you can use it vaginally. Okay, on day one, I am giving mifepristone. I am sending her home. Okay, on day one, I gave mifepristone 200 milligrams. I sent her home. Now, on day 3, what she will be using? So, she will be using the sublingual 400 microgram of misoprostol. Now, in home. So, after doing that, she will be going to have a bleeding. Okay, she will be going to have an abortion. So, abortion completed. Okay, medical termination. Okay, abortion via medical termination is completed. So, I will be asking her to come on day 15th for the follow-up examination. I will ask her what is the amount of bleeding? Is everything okay? Are you having any fever, any abdominal pain? Okay. If she is saying I'm having too much amount of bleeding, I have bleeding here and then, I'm having fever, chills, pain in the abdomen. Now I will be suspecting that there is some problem happening in the uterus, might be because of some retained products of conception. So what I will be doing, I will do ultrasonography. If I find any retained products, I will remove them by dilation and curettage. So on 15th day, you have to ask the female to come for the regular follow-up. So 99% of the time, by following this regimen, 99% of the time there will be success. So till 7 weeks, what I am doing? Mifepristone plus misoprostol. Mifepristone on day 1, misoprostol on day 3. 99% success will be seen. Okay. Now, after 7 weeks, till 9 weeks, can you do medical abortion or not? Yes, you can do medical termination. So, between 7 to 9 weeks, what I am going to do? I will be doing the same thing, same drugs I am giving. See, on day 1, I am giving 200 milligrams of mifepristone. Orally, it's an anti-progesterone, it kills the fetus. On day 3, instead of giving, this is the important point, instead of giving 800 micrograms, okay, now this female, instead of taking 400 micrograms, now she should take 800 micrograms of misoprostol. How she should take? She should take it as a vaginal, in the vagina, she have to keep this prostaglandin E1. How much? 800 micrograms should be kept, and that causes uterine contractions, expels the baby. So first 7 weeks, just 400 micrograms of that misoprostol or misoprost is used, but 7 to 9 weeks, 800 micrograms of misoprost was being used. Same on 15th day, she have to come with the follow-up examination. The success rate will be 95%. Okay. Now, we have discussed about the medical termination in the first trimester. See, for the first 7 weeks, what is best? For the first 7 weeks, the best method will be medical termination. After 7 weeks till 12 weeks, the best method will be suction evacuation. Okay, but Just wait. See, Misoprostol. Have we studied about Misoprostol anywhere? Yes. Misoprostol can be used for treating the postpartum hemorrhage. It can be used for preventing the postpartum hemorrhage. So, for treating postpartum hemorrhage, what is the dose of Misoprostol I have used? I have used 800 microgram rectally. This is important. 800 microgram rectal Misoprostol used for treating the postpartum hemorrhage. See, for treating postpartum hemorrhage, we have used oxytocin, we have used 𝗜𝐺𝐼𝐻, that kind of drugs, right? In the topic of postpartum hemorrhage, we have discussed in detail. So, Misoprostol can also be used for treating postpartum hemorrhage, 800 micrograms rectally. For prevention of postpartum hemorrhage, you can use this Misoprostol. How much dose? 600 microgram orally. For labor induction, you can use 25 to 50 micrograms of Misoprostol every 3 hours. You can use like that for next 5 to 6 times. So Misoprostol, it can be used for treating postpartum hemorrhage, for preventing postpartum hemorrhage, for labor induction, also for medical termination of pregnancy. For medical termination of pregnancy, just wait for MTP. See, MTP is happening in the first 7 weeks. What is the dose of Misoprostol used? 400 microgram. Okay, 400 microgram. But 7 to 9 weeks, what is the dose of Misoprostol used? It is 800 microgram vaginally. Okay, so completed. Now let's see about important points about the suction evacuation. See, suction evacuation is best between 7 to 12. Before 7, it is medical abortion or medical termination. Now 7 to 12 weeks, it is suction evacuation. For suction evacuation, the instrument which is going to be used is 𝐒𝐻𝐫𝐼𝐻 cannula. Okay, this 𝐒𝐻𝐫𝐼𝐻 cannula is that suction that suction device. With that, we are going to suck out the baby. By creating the suction, we are taking out the baby. What is the size of the cannula, guys? What size cannula should be taken? See, whatever is the period of gestation. For example, now her period of gestation is 10 weeks. You have to take a size of the cannula 10 or -1. Okay, so the cannula size should be equal to the period of gestation or -1 of the period of gestation. If she is 10 weeks, either you should take the cannula of size 10 or size 9. Okay, like that. Now, the pressure generated in this suction and evacuation is going to be 600 mmHg. With 600 mmHg, you are going to suck out the baby. And before inserting this 𝐒𝐻𝐫𝐼𝐻 cannula, actually you have to dilate the cervical os. Okay, first you have to dilate the cervical os gradually with the help of 𝗓𝐺𝐼𝐻 dilators. Okay, so you have to keep these 𝗓𝐺𝐼𝐻 dilators gradually so that the cervix will be dilated. Later you are going to do the suction evacuation. Okay, now how to know what is the end point of suction? See, you are doing the suction evacuation. When to know that the entire suction of the products of conception completed? When to know? See, there are these signs like air bubbles are coming inside the cannula. There is this grating sensation. Okay, you will feel the grating sensation. Why? Because now the suction is actually gripping onto the walls of the uterus. Grating sensation is there and bleeding starts to decrease. So bleeding is getting decreased. You are seeing the air bubbles in the cannula and grating sensation is felt. Okay. Now after that, what are the complications which are seen with the suction evacuation? Before doing suction evacuation, are you dilating the cervix or not? Yes, sir. You are dilating the cervix with the help of 𝗓𝐻𝐼𝐻 dilators. So when you are doing so, there is a chance that uterus might be ruptured. So uterine rupture can happen. Okay, sorry, not uterine rupture. Uterine perforation can happen because of perforation with the 𝗓𝐻𝐼𝐻 dilator. Now what to do? If there is a perforation because of 𝗓𝐻𝐼𝐻 dilator, now this perforation is going to be very small in size, so that usually there is no need for you to intervene. Okay, so if there is uterine perforation because of the 𝗓𝐻𝐼𝐻 dilator, don't do anything, just wait and watch. Monitor the vitals of the female, because this perforation will heal by its own. Why? Because the perforation is going to be very small in size. Now, if the perforation is because of suction cannula, okay, that 𝐒𝐻𝐫𝐼𝐻 cannula, this perforation is a more dangerous perforation. So what you have to do is, you have to immediately shift her to the OT and do the laparotomy. Okay, do the laparotomy and repair the perforation accordingly. Okay, so this is about the suction evacuation. Now let's talk a few important points about manual vacuum aspiration. Guys, manual vacuum aspiration means you are going to do the aspiration of the baby. You are going to take out the baby by manual vacuum generation. See, here you are going to hold, and you are going to drag back. So it causes vacuum. It causes vacuum. Why we are using this manual vacuum aspiration? Because in villages, in rural settings, electricity won't be there every time. So in village environment, in rural setting, this manual vacuum aspiration is best. It almost generates 660 mmHg of pressure. Okay, very good pressure is getting generated. What you are going to do? You are going to take this manual vacuum aspirator syringe and you are going to attach a Karman's cannula anteriorly, and you are going to create a vacuum, and with this vacuum you are going to do the aspiration. This is best in the rural settings, and the volume of this manual vacuum aspiration syringe is somewhere 60 ml, and this is used especially in those conditions where there is no electricity. Okay, now please see guys, here whatever you are seeing here is this is a Karman's cannula anteriorly, and with one hand like the suction is getting generated here. Okay, so this is all about the manual vacuum aspiration. Now let's talk about the second trimester medical abortions, guys. We have seen the first trimester medical abortion. We have seen what are the drugs which are being used, and what is the dose of drugs which are being used. Now in second trimester, that is after 12 weeks. See, medical abortion can be done, yes, and the medical abortion is done by prostaglandins. Very important thing. See, we are going to do the medical abortion with prostaglandins. What are the drugs which are used? See, not the day, just strike out the day here. Okay, now this is just the numbers. Now see, the most favorable drug that which we are going to use is the Misoprostol. Okay, Misoprostol, that is PGE1, Misoprostol. Now see, we are going to use this drug Misoprostol, 400 micrograms. Okay, 400 micrograms of Misoprostol. We are going to keep it vaginally for every 3 to 4 hours. For every 3 to 4 hours, I am giving this Misoprostol via vaginal route. How many times I will be giving this? 5 doses. This is the MCQ. Maximum doses of Misoprostol even for second trimester abortion is 5 doses. Every 3 to 4 hourly, I am keeping this Misoprostol inside the vagina. I also remember that the second trimester medical abortions are done in hospital, not in OPD management. Okay, keep that point in mind. So what this Misoprostol is going to do? This Misoprostol is going to cause the uterine contractions that expels the fetus. So second trimester medical abortions are done with prostaglandins. Okay, prostaglandins. So other prostaglandins like dinoprost, which is a PGE2, can be used. So how much, guys? 20 milligrams vaginally. Okay, one single time 20 milligrams vaginal suppository was kept. It causes the uterine contractions and expels the fetus. I can also use the drugs like a carboprost, which is prostaglandin F2 alpha. 200 micrograms of this drug can be given intramuscularly. Okay, every 3 hours, and you can use this drug for 10 times. Okay, 10 doses can be used, and every time you can use 250 micrograms of prostaglandin F2 alpha. It is also going to cause the uterine contractions and expels the fetus. Okay, this is the medical management. Okay, this is the medical management in the second trimester, which was done in the hospital with the prostaglandins. See, this is the best. Especially we are going to stick to this Misoprostol, prostaglandin E1, 400 micrograms every 3 to 4 hourly for 5 doses. That's the best. Okay, it's going to cause the abortion for sure. But there are certain outdated techniques which can be used in the second trimester. Now, those outdated techniques includes intra-amniotic prostaglandin injections, extra-amniotic ethacrynidine lactate, extra-amniotic hypertonic saline, extra-amniotic hypertonic urea. Okay, they can also be used, but they are outdated because of their complications. In second trimester, from 12 weeks, okay, after 12 weeks, what is the best? The best is going to be medical abortion with prostaglandins. Okay. Now, having said that, let's continue and discuss a few important points. Please concentrate, guys, here. Period of gestation. Before 7 weeks, what is best MTP? See, it's a medical abortion. Mifepristone plus misoprostol. 200 milligrams of mifepristone on day 1 and 400 microgram of misoprostol on day 3. 99% of the time abortion will happen for sure. Okay, that's what we do before 7 weeks. Now 7 to 12 weeks, what is best? 7 to 12 weeks, the best thing is going to be suction evacuation. Okay, suction evacuation is going to be best. After 12 weeks, we'll be doing MTP mostly with the prostaglandins. We have completed all the important points regarding the medical termination of pregnancy. Hope the video is helpful. Thank you.